Good afternoon and welcome to our web-based seminar called Best Practices in TB Control, Enhancing Supportive Social Services for TB Patients. My name is Rajitha Bavaraju and I'm a Training and Consultation Specialist at the New Jersey Medical School Global Tuberculosis Institute. TB surveillance data indicate that many TB patients include foreign-born, homeless, substance abusers, refugees, migrants, and HIV-infected persons. Peer-reviewed literature and best practice has indicated that the inclusion of supportive social services in the care of these patients enhances treatment adherence and outcomes. This web-based seminar will cover resources that can be utilized to assist at-risk TB patients. We will do this through a multiple-layer approach that looks at TB patients as individuals, as well as how practitioners can enhance service through system-wide interventions and through program collaborations. Our faculty members today are Dr. Paul Coulson, Dr. Adeline Neymathy, and Ms. Kristen Gall. After this introduction, Dr. Coulson will provide an overview of social support services and the need for such services in the care of patients with TB. This will be followed by Dr. Neymathy and Ms. Gall. We will then have time for questions and discussion after Dr. Coulson and then again at the end of the program. I would like to now begin with Dr. Paul Coulson. Dr. Coulson is the Program Director of the Charles P. Felton National Tuberculosis Center in Harlem, New York. Dr. Coulson has been the principal investigator on numerous studies and author on many papers related to treatment adherence and behavioral interventions with the homeless, mentally ill, and other vulnerable populations. He will provide an overview of supportive services for TB patients and end with a case presentation. Paul, I'd like to turn the program over to you.
Thank you, Rajita. What I'd like to do is briefly present some background about social support needs and some of the populations that might have these needs. As many of you know, in TB control, increasingly, U.S.-born TB cases represent the most disadvantaged members of society. According to TIMS data from last year, homeless people represent almost 6% of U.S. cases, injecting drug users, 2%, drug users who do not inject but use other drugs, around 8%, and alcohol users around 13%. Foreign-born patients now represent over half, around 58% of all TB cases in the United States. So while there will be some overlap between these various categories, you can see that by far the majority of people might be in categories that could use social support services. Now, why would these groups need social support services? There may be language or cultural barriers, particularly for the foreign-born. For many, treatment for TB or latent tuberculosis infection may be a low priority. There may be poor adherence due to differing beliefs about the disease and its treatment, and due to life circumstances, such as being homeless or abusing substances. These groups often have multiple needs, but lack resources to meet many of these needs. And why is it important for us to step in to try to provide these services? We want to improve adherence and treatment completion. We want to prevent the development of drug-resistant tuberculosis and try to reduce the transmission of tuberculosis, including drug-resistant strains. One of the social support services that a TB clinic could provide is to do a psychosocial intake. Now, this might be, as the first bullet suggests, an intake for all patients or on an as-needed basis, with either patients self-referring or a referral coming from a medical provider. Ideally, it would be conducted in a private setting, and it's a first step towards establishing a therapeutic alliance with the patient to help them with these issues. It's important that confidentiality is maintained, and one should start with the client's definition of a problem that they're facing, such as maybe a housing problem, although you may have to deal with issues further down the road that the client does not identify or deny, such as substance use. An intake would consist of a biopsychosocial assessment. This includes patient information, the reason for referral, a psychosocial history, the current living situation and functioning, your assessment, both sort of objective and subjective assessment, and then a plan listing short-term goals and long-term goals. Case management is another important supportive social service. Case management is an interdisciplinary approach to patient care and is used in a variety of ways. Managed care companies often use case management to limit services. What I'm discussing here is more inclusive approach to case management that tries to address the variety of needs that a patient may have. Case management would include input from physicians, nurses, social workers, health educators, outreach workers, other people involved in the patient's care. And it often requires meetings where information is shared and insights from different disciplines are offered. In a case management meeting, one may discuss a newly diagnosed client and what his or her needs might be, significant new problems that have come up during treatment, change in medication, what impact that might have on the patient or other circumstances, and steps towards treatment completion. The process in these meetings would be to share information so that everyone is updated about current situation, for different members of the team from different disciplines to share their opinion, and to identify goals and action steps. Referrals is another important supportive service. Obviously, there are many services that a patient may need that cannot be provided in the chest clinic or the TB clinic or even perhaps in the hospital and need to be referred out to community agencies. These things may include public assistance programs, shelter or other housing programs, food programs, clothing or other tangible goods, substance abuse treatment, and agencies which assist immigrants, particularly those who are undocumented. It's important when making referrals to not simply write out a form and send the patient off, but rather accompany them if they have concerns about how they'll be received at that agency, and to follow up with the agency afterwards to make sure that everything worked out. Some other supportive services that may be important would be targeted health education, support groups, and counseling. Some of the ideas I've just been discussing over the last few minutes are covered in more detail by the third publication listed here. There's a manual that my center produced called Social Support Services for Tuberculosis Clients. And that is available from our website, but I believe, Regina, there's also a link somewhere through this presentation. What I'd like to do next is just to provide an example of how social support services can help a patient by talking about a case study. And I'd like to talk about Mr. A, who was an LTBI patient at Harlem. Mr. A was a black man in his mid-40s who lived in Harlem. Following a positive skin test, he was found eligible for LTBI treatment. He was referred to a research project we had there, and he began treatment. Outreach worker Viney G was assigned to help him be adherent. Viney found it difficult to get to know Mr. A. He was quite volatile. Sometimes when Viney ran into him at the hospital, he ignored her. However, he also refused to speak to anyone except Viney. He often dropped into the project offices, even when he didn't have an appointment. There are also long periods in which he failed to appear, could not be located, or refused to come in, even when we encountered him on the street. Now remember, he's an LTBI patient, so we could not force him to come in to our office or to engage in treatment. Mr. A called Viney once, complaining that his apartment had been broken into. She visited the apartment and found out this was true. She suggested he call the police. When they arrived, they were concerned about her safety, asking her, "Do you know who you're dealing with here?" Mr. A was well known at the local precinct house for causing disturbances, both in his building and on the street. Up to this point, Viney only had access to chest clinic records. She was then able to see his hospital chart and saw that Mr. A had been diagnosed in the psychiatric emergency room as having schizophrenia with paranoid features. As far as she could tell, Mr. A was not receiving psychiatric care at Harlem Hospital or other agencies. When she broached the subject with Mr. A, he angrily left the office. Viney consulted with the program director and the study investigators, which included a psychiatrist, and particularly we asked the psychiatrist's views on what should be done next, and he reminded us that he didn't have any magic dust to sprinkle over the patient and make him cooperate, that what Viney was doing was actually the best approach. She was creating a relationship with him where she was gradually earning his trust, and he was starting to interact more regularly with her. We felt that if we tried to push him into mental health care, that he would probably disappear because he did not acknowledge his illness. And if pressed in a direction that he didn't agree with, that he would just drop out of treatment. So it was decided that Viney would continue to try to meet his needs while continuing to build a sense of relationship. And this would pave the way for eventual referral for mental health services. Now, Mr. A was having a lot of problems with his teeth, so Viney arranged for a referral to the dental clinic and accompanied him to his appointments. He was also receiving inappropriate hospital bills, which made him very angry. Viney took these bills to accounts receivable to have them canceled and his account closed. After she began speaking to him about getting an HIV test, he disappeared for several weeks. Mr. A came to see Viney again because he had been summoned for jury duty. He had repeatedly failed to respond to earlier summons and was at risk for being incarcerated. Viney told him he'd be able to get a deferment if he acknowledged his mental disorder, and he agreed. She then referred him to a community mental health agency and accompanied him on his first visit. Although he attended only erratically in the first few months, he eventually became a regular client. Around this time, Mr. A finished his LTBI treatment. Although Viney could not continue to work with him, Mr. A would often drop by the office to chat with her after this point. I wanted to bring out this case study to discuss several key features. Obviously, the efforts towards establishing rapport was very important. There was a certain amount of tolerance that was needed. Mr. A, as pointed out, was volatile and uncooperative, but Viney hung in there and kept trying to reach out to him. Learning his psychiatric diagnosis was important, but didn't drastically change her activities, other than focus a little more on trying to eventually achieve that mental health referral. Viney was there to provide different forms of tangible assistance, which made a difference in his life. Supporting him when he went to new places for appointments, helping him get rid of the troublesome bills, getting his teeth fixed. Obviously, there was a certain persistence in her efforts that was very important on achieving an outcome. And again, the strength of the relationship that was formed, I think, really had an impact. While it was difficult at times, in the end effect, he cooperated. He started attending the mental health clinic, and he maintained a cautiously friendly relationship with Viney. I'd now like to open the floor if there's any questions about this case or comments people would like to make.
Hi, this is Jesus Ortiz down at A.G. Holly State Tuberculosis Hospital down here in Lantana, Florida. That was a good case, and I have a behavioral medicine department here listening in and participating here. Just a couple comments. The establishing rapport with the patient is critical, and it can take time. Just sticking in there and be perseverant, helping him address some of his other needs can also help build that trust. There is one concern about that case, and not just that case. It's a similar case like that when you have the outreach workers going out and to where the patients are, and I worry about that all the time. Because you could be going into an area that potentially is dangerous to the outreach worker, and ways to address that. It might have helped to perhaps, in some cases, have somebody else go with that the outreach worker, so it could be safe. There may be occasions when you go to places that you may need a little bit more support as far as finding someone and addressing them, because it could be very dangerous. Depends on the neighborhood you're going into or the particular person. Like this one has a history of being potentially violent, and going to his apartment all could have been, I mean, this had a good outcome, but it could have turned into a very unpleasant and tragic outcome. So bringing support to be able to deal with the particular situation can be helpful. So that's the main comment on that.
Thank you. I would just add, certainly having someone accompany Viney would be a good idea. That's something we weren't able to do given the size of the project back when this happened. The other thing I should point out is Viney was a lifelong Harlem resident and knew the community very well and knew how to protect herself. In fact, there's probably not much I could have told her about safety in the field that she didn't already know. But again, that was an unusual case, someone who was very street smart and your cautions are well taken. Thank you.
Your next question comes from the line of Melinda Diaz.
Hi. I have a comment, and I think that the nurse did a wonderful, marvelous job, and I would like to know, a lot of nurses out in the field don't know what resources are out there or who to go to find out those resources. Who did this nurse use? What were her resource people in order to know that if, he said he had a mental illness, he didn't have to go to juror's duty, and how to get his hospital bills taken care of? What would you advise nurses out in the field to search out?
Well, just a quick correction. Viney was not a nurse. She was an outreach worker. Her supervisor was an MSW, a licensed social worker. So her supervisor was well aware of many of the community resources, again, was also very familiar with the Harlem community. So I would think that nurses in TB clinics, if they don't have a social worker on staff, should try to reach out to, if you're in a hospital setting, the social work department, or perhaps some key community agencies to start with. In many communities, there are social service directories, either produced by United Way or other organizations, and you should try to get your hands on those. And probably, physically first try to map out which of the agencies that are closest to your clinic and the ones being most used by your patients.
Thank you.
Thank you, Paul, for answering those questions. In the interest of time, I think we're going to need to move on to the next presentation. So I thank those of you who asked the questions. We did get one question through the Q&A on the Internet, and that question is, it's a comment, and it's from Rosalind at Doctors of the World. And the comment is that what stood out for me in this case is the lack of a coordinated electronic medical file system so that Viney could find out Mr. A's previous diagnosis from the first time he was registered as a patient. And, of course, this is a wider U.S. systems issue, so it, I think, speaks about the issue of coordination and perhaps finding systems that might make it easier to coordinate those systems so people can find out better information about their patients and more complete information about their patients. Our next speaker is Dr. Adi Naimathi. Dr. Naimathi is the Associate Dean for Academic Affairs and the Adrienne H. Mosley Endowed Chair at the UCLA School of Nursing. She has received numerous awards in the fields of nursing and research and has published extensively in the area of health in vulnerable populations, including TB patients. I'll now turn the program over to Dr. Naimathi, who will talk about a model for enhancing services for homeless persons. Dr. Naimathi?
Thank you. Good afternoon to everyone. It's a pleasure to be with you all today virtually. I'm going to present findings on a NIDA, National Institute on Drug Abuse funded study, which was designed to assess the effectiveness of two programs on enabling homeless adults to complete a latent tuberculosis infection treatment. And what we know is that homeless individuals, and I'll be speaking about adults right now, are really a population to be concerned about in terms of being at high risk for tuberculosis. That is because of a number of factors. For one, their compromised immune system. We know from our research and other data that currently about 75% of homeless individuals, and I'll mention specifically from my study, are actively and currently using non-injection drugs, for example, crack cocaine. They live in overcrowded situations, poor nutrition for the most part as well, and they lack access to health and social services. In addition, adherence, as we've heard with Dr. Colson, is a problem. Fortunately, treatment is there, and if we can get someone to complete treatment, they can reduce the risk of progression to active TB by within a range of 64 to 93%. Unfortunately, homeless individuals have issues with adherence. And as you can see from this slide, it could range from 19% to 44%. And actually, when we began our study in Los Angeles, less than 10% of homeless populations were completing LTBI treatment. So therefore, the specific aims of our study were to compare the effectiveness of a theoretically based comprehensive program which employed nurse case management done by nurses as well as outreach workers assisting against a usual care group which was related to LTBI treatment completion. In this study design, as I mentioned, there were two groups. They were randomized by site, and the sites included 12 different homeless shelters or drug rehab programs that were more in the realm of being residential programs. The age was 18 to 55 or over 55 if they had reported risk activation factors. They had to have been homeless the previous night and had to have denied receiving previous treatment. We did the skin testing. We looked at induration if it was over 10 millimeters for an HIV seronegative individual or greater than 5 millimeters for an individual who was seropositive. The theoretical base was actually a framework that I used in my dissertation many years ago, and what I like about this framework is it's very similar to what Dr. Colson was saying. We look at multiple variables, not just adherence. We look at what their situational life current situation is, their drug use. We look at social support. We look at how they're coping. All kinds of things, and that's important for us to be able to to actually provide a comprehensive program as well, because we are assessing all of these variables. In the nurse case managed with incentive, that's what the NCMI stands for, we delivered a program that was over several weeks. We focused on TB and HIV risk reduction. We also were very interested in helping with problem solving, because that is important in terms of making behavioral changes. We also focused on communication skills, and particularly because they're working with nurses and outreach workers, and we wanted to make sure that they were able to manage their time, because they actually had to come into a clinic in the Skid Row of Los Angeles, which was central to all of them, to receive their directly observed preventive therapy biweekly for 52 doses. And we provided an incentive of $5 every time they came in. In terms of the what we call the traditional or the usual care program, it is exactly usual care. The only thing that was different is we gave them a 20-minute education session about TB and HIV. They also had their preventive therapy biweekly for 52 doses, and they got their $5 every time they came in, because we cannot have a comparison if only one group was getting paid and the other group wasn't. So that was the design of our study. And traditional assessments were monitored, including drug and alcohol use. We logged completion of the DOT. We measured social support, depressive symptoms, psychological well-being. These are just a few of what we looked at that was guided by the model that we talked about. We did a baseline and a 6-month follow-up. There were 520 participants in the study. We had a 98% follow-up, and this is a very important aspect of research, is to be able to track and find participants who come into the study. And the ways that we did that are, for one, respecting confidentiality. And we always said that this is a public health study. It's not a tuberculosis study. We did a very detailed locator guide mentioning about the issues of confidentiality. We were approved by our Human Subjects Protection Committee to take a photo of the participants, which we only used among the staff. And we were allowed to check prison and jail rosters, and at times were able to get the nurses within these institutions to continue the treatment for us. But most of the time we had to do it when they got out. And then, of course, we were very clear about who was to be contacted and who wasn't. That was all documented on the locator guide. And I think the most important thing is to never give up and continue to track unless they tell us they don't want to be contacted. Of course, we would honor that as well. In terms of the results, we did an intent to treat analysis, and we were able to capture 62% of the nurse case managed and incentive group, the NCMI group, compared to 39% of the usual care group. In terms of just looking briefly at the data, what we found out, again, the 520 were divided into 283 and 237, and the average age, as you can see, is about 42 years. In terms of education, about 12 years. And the one thing that we see is that the males were a little bit more prevalent, as you can see in the nurse case managed, as compared to the traditional group. But all of these differences that are at baseline were controlled statistically. About 80% were African American, and much fewer were either white or Hispanic. This is representative of the population in Skid Row, Los Angeles. There were no differences with social support. The social support was moderate. However, an important issue to think about in terms of social support is not whether they're getting support, but whom are they getting support from? Is it from drug users or non-drug users? That's important. Depressive symptoms were high. Based on the CESD, if it's over 16, they are at high risk for depressive problems. So that was something that we referred our clients for mental health care. And psychological well-being was also on the low side. Continuing with baseline characteristics, we can see, again, some differences here. What we're seeing is that the individuals that were in the traditional group had higher percentage of lifetime injection drug use, also higher percentage of current injection drug use. But the most predominant drug, as you can see, the non-injection drugs such as crack cocaine, which was the most prevalent, was no difference between the two, not statistically different. And no difference with alcohol use, so we had about 16% were daily alcohol users, almost a quarter were daily drug users, and many of them smoked for many years. What's interesting is that at baseline, everybody says they want to adhere, they want to take INH. As you can see, it's in the 80 percentile. And medical discharge was not different between the two groups. We had to check liver enzymes every single month, and when they were becoming high, because many of these individuals are alcoholics, we had to stop them from treatment, and some of them we could never put back on, others we could. But there was no difference between the two groups statistically. Now we're looking at completion, and what we see here is that the intent to treat, as I mentioned earlier, was actually 62 and 39. But when we did the traditional completion, it was 72 and 46%. In terms of age, we see that there was a difference, that the completers were slightly older than the non-completers. In terms of ethnicity, we saw that the African American group were more likely to complete, and the Hispanic group, as you can see here, were less likely to complete. And a difference with recruitment, those who came from a homeless shelter were more likely to complete than those who came from a drug recovery shelter. No difference with social support, depressive symptoms, or psychological well-being. In terms of lifetime injection drug use, we see again that the individuals that had a history of injection drug use were less likely to complete. This is the non-completer group here. There was no difference statistically with injection drug use, and no difference with the non-injection drug users. We do see alcohol as a variant here, that they were more likely not to complete if they were daily alcohol users. And same thing here, if they were daily serious drug users, they were also more likely not to complete, or less likely to complete. Here we're looking at odds ratios, and it tells us that looking at the nurse case managed and incentive group, they were 2.25 times more likely than the other groups to complete the treatment than the other group. There was also a slight increase also when age, as the individual got older, they were more likely to complete, and more likely to complete if they were African American, as we said earlier. When we look at those who have a history of of poor health, and the way we measured it is if they were hospitalized in the last 6 months, we see a negative relationship, so that they were less likely to complete, and also less likely to complete if they were daily alcohol users. And getting to the end here, we did actually a sub-analysis looking at these particular groups in terms of completion. And you could see that there were some subgroups that were much more likely to complete just when we looked within the subgroup itself. And you can see women, for example, were almost 6 times more likely to complete. Those who were daily alcohol users, even though they were a problem, they were more likely to complete as a group within themselves. And those who were veterans also had a 4 times more likelihood of completion. So in summary, our findings indicate that 72% of homeless persons in the Nurse Case Manage program completed the latent tuberculosis infection treatment, while 46% of those in the traditional group completed treatment. So a highly significant difference between the two programs. And completers were more likely to be older, to be African American, and to be recruited from a homeless shelter. The non-completers were more likely to be Latino and to have used lifetime injection drugs, to drink alcohol daily, or to use serious drugs daily. And strategies that are utilized by nurses and outreach workers in the Nurse Case Manage program, including case management, incentives for enhancing compliance, and relocating clients to return through means of tracking are very helpful. Compliance to medication regimen among the group that you think may be least likely to come back is possible with effective strategies. And what I have listed for you are several of our publications that we have published from this data set. Thank you.
Thank you, Dr. Naimathi, for your presentation. And just a reminder to everyone, if you were able to access the handouts page today, several of these publications are posted there as well as posted through this website, so you can certainly access them to get more details. Since we're doing fairly well on time, I think we could take 1 or 2 questions for Dr. Naimathi, if you wouldn't mind. Dr. Naimathi, we have 2 questions actually that came in by the internet. So the first one is just a question about terminology, and that is, again, how did you define the term serious drug user?
Serious drug user were drugs such as methamphetamine, crack cocaine. Those were the main serious drugs, as opposed to, for example, marijuana or one of those.
Okay. And then another question that came in, the question says, do you have case managers go through cultural competency training? And so maybe you could speak a little bit about the background of the nurse case managers that were part of the study, and then perhaps what might be some of your recommendations sort of in practice out in the field in terms of training for those nurse case managers who might implement a process like this.
Yes, I think that's a very good question. Case managers absolutely need to go through cultural competency training. We absolutely did that for our research staff. We do it with every research study that we have beginning, because it's not only about the population that you're working with, it's also about maybe the differences in drug use, perhaps, for example, working with the prison population versus the homeless population versus another. There's a lot of competence about the population you work with, as well as the ethnicity and issues that you need to deal with, of strategies which would make them much more interested in having a rapport with you in terms of issues of adherence and all of that. So we do train by means of specialists that are in the competency area, as well as those who are within the expertise of where the populations come from, so drug addiction or homelessness or any of that.
Yes, ma'am. Your next question comes from the line of Julia Moore.
Yes, I was wondering if she could explain again the difference between her nurse case managed and the traditional.
The differences, Julia, between the two are the fact that the nurse case managed got a number of sessions with the nurse specifically, and the sessions dealt with not only extensive information about TB and the implications about contagiousness, but issues about self-management, about how to deal with time management, problem solving. We did also talk about drug addiction as issues that they're dealing with. We dealt with issues of social service, what kinds of needs do they have. So we did the full case management regimen that was similar to what Dr. Colson also talked about. We did walk them over to referrals, and our outreach workers were good about doing that. We got them into health care. So that was what the case management was all about, and always emphasizing the importance of completion of this program. The usual care received only that 20-minute discussion about TB, as well as HIV, and then the program was initiated where they met twice weekly with the nurse for their dosing.
Yes, ma'am. Your next question comes from the line of Marcia Stone.
I was wondering if you could describe the locator guide that you used.
Yes, the locator guide comes from Dr. Doug Englund, who is here at UCLA Integrated Substance Abuse Program. It is a 3-page document that basically outlines their information, name, where they're currently staying. Of course, that changes from day to day. But then most importantly is where their hangouts are. Where are their friends, what the phone numbers and addresses of their family members are. And so friends, family members, relatives, all of that. And we tell them that if we cannot find you, we will go through your list and call all the contact information. So that's when they will tell us if there are particular people they don't want to be called. We honor their what they're telling us, and also, as mentioned, we don't call it a TB study when we are making phone calls. And our nurses and outreach workers walk the streets all the time. We are very savvy to protection. We have meetings with the police department to talk about safety issues. They always go together in pairs, and we are very, very cautious about issues of safety, particularly in the Skid Row area.
Thank you, Dr. Naimathy, for your presentation, and I noted that there are quite a number of questions that have actually come in through the web. So at the end of today's conference, the third presentation, hopefully we'll be able to answer some of those questions and take additional questions on the phone line.
Thank you.
So I'd like to now turn the program over to Ms. Kristen Gall. Ms. Gall is a community mental health nurse in Nebraska Department of Health and Human Services in the Division of TB, STDs, HIV surveillance, and refugee health. Now that we've talked about enhancing supportive social services on an individual and an organizational level, Kristen will be now talking about working at a larger program level in her work with the refugee population. So, Kristen, I'd like to turn the program over to you.
Hello, everyone. Thank you for having me today, and I will be talking about Nebraska's collaboration in working with refugee populations. Just to give you a little bit of background about Nebraska's TB program, we are a rural state, and because of that, we don't have as much TB as some larger states, and because of that, we do have limited staff available to follow up on our TB folks. In our state, we do have local health departments that are scattered across the state. We do have 21 county district and county health departments, which do help us quite a bit with the TB follow-up. We do have 2 full-time nurses in Omaha and also a half-time nurse in Lincoln, which are our 2 largest cities in the state. So they are pretty self-sufficient in dealing with TB, but once we move out of that circle, we don't see that much TB, and our health departments are there to follow up on our patients, but they really need a lot of assistance from the state to manage these folks that do have TB. Looking at the foreign-born population in Nebraska, just to give you an idea of what kind of numbers we do see coming into our state, we had 301 refugees arrive in 2006 in the fiscal year, and then we did have 490 arrive in the fiscal year of 2007, and those are the newly arrived refugees. And then, more importantly, we do receive quite a few secondary migrants. And when I talk about a secondary migrant, I'm talking about a refugee who has relocated initially to another state and has since then resettled into Nebraska to make Nebraska their home. A lot of secondary migrants do come because of their family connections or they hear about jobs. One of the biggest employment opportunity in Nebraska that we see a lot of refugees working in are the meatpacking plants. Looking at sort of our numbers for TB cases in the foreign-born for the last 5 years, you can see we do have about 20 to 30 cases a year of TB. And a very significant statistic last year in 2007 was that all 25 cases of our defined TB cases in Nebraska were among the foreign-born. We did not have any U.S.-born cases of TB last year in our state. And what we're aware of is that was the first in the nation of its kind per our TB controller. Some of the challenges we see within the refugee population is the complex American healthcare system. When refugees get over here or when they're just starting out, they've got enough things to worry about, to put food on the table, to have a job. And then we're throwing the complex American healthcare system such as insurance, co-pays, how do I get to the doctor, the need for being on time to appointments. In other cultures where being on time isn't as important as it is here in the U.S. Another problem is we do have a very work-focused environment in our state. Once refugees get here, the focus is to get the refugees employed so they can self-support themselves and get insurance through their employer. Of course, language is a problem. When refugees don't speak English, then they don't know where they can go and people will understand them or how that all works, the availability of interpreters. Another major problem is the lack of resources that refugees do have access to, such as transportation, health insurance. They may be living in a poor, crowded living condition. There may not be a job or no money coming into the household. And also a lack of knowledge. Something with, of course, latent TB is you don't have any symptoms except a positive skin test. And if you're not feeling sick, why should I be taking TB medicine? So all of those factors are barriers for refugees accessing the healthcare system. What our focus has been in Nebraska is to do a lot of education with a variety of agencies. And why we've really done this is for quite a few reasons. There's a lot of fear of catching TB when we have agencies that directly serve refugees, and they're scared they're going to catch TB when they are working with a client. Also, a lack of information. Many people hear you're talking about TB and they think it's the active form of TB, but they don't know about latent TB infection and how that's not infectious. Many don't know about the overseas screening process, how refugees are classified, and refugee resettlement in the U.S., or what exactly is a refugee. Some people think a refugee is similar to an immigrant, which they're two very different groups that do resettle in the U.S. Also, being a rural state, it is hard for us to know at the state what is going on in all our smaller health departments, and so we really value the local health department information to what's going on in their area, if there is a concern about TB, or if there some type of thing such as lack of information or fear in the community. And also, of course, the state, we're involved trying to manage all of these issues to make sure agencies are informed of TB and refugees and the proper way to get people services. One of the big roles from the state perspective is networking with our agencies that do serve refugees. one of the biggest successes has been working with the Refugee Task Force. And we do have Refugee Task Forces in Omaha and Lincoln, and there is another more informal group meeting out in Lexington, Nebraska. And who attends these meetings include refugee resettlement staff. We do have refugee community members attending. We have local organizations such as workers for Medicaid, hospitals, health departments, clinics, support groups, resources for refugees. And sort of by having all these connections really helps people network and take advantage of resources that are offered by different organizations. I know I had been at the Omaha Task Force not too long ago, and there was a gentleman who wanted to do some outreach HIV work out in the rural part of the state, and I had connected him with the local health department out there because there wasn't that connection. So a lot of the networking process goes on at those meetings. Of course, we have our State Refugee Resettlement Coordinator, Karen Party, who is very much involved in our Refugee Task Force meetings, and then, of course, our local health department staff who can voice local concerns that may not be evident from a state perspective. One of the big things I've really focused on in Nebraska is getting the word out about TB to our colleges. And this was sort of brought on by a college outbreak that we had in our state. And there was also, at the time when we were working on this case, there was also proposed legislation in Colorado after a student had died of TB on a Colorado State college. And so as we do see more foreign-born people enter our state, we want to have information available for our college staff who are serving the students. We don't have any state law for TB testing in our colleges, and for me it was very difficult to find information about policies on the internet. And something that was very interesting to me is when we had the college outbreak, how the administrator was very unfamiliar with TB and why it's important to be screening for TB on a college campus. What we want, of course, is students to be healthy, to do their school, and not to break down with TB and have them succeed in the classroom. Something else that we are seeing in our states, we do have a couple of interpreter, translator, college coursework offerings. And so we are seeing more, we are catering to this population for continuing education. What I went ahead and did was there's a product by Heartland National TB Center called TB on the College Campus. And I sent that out to colleges, and it's a guide on how to collaborate with the health department, school, and how students to deal with TB. And at the very least, we wanted to know colleges to know that there was a TB program and local health department available to assist with TB issues and is a resource to help them deal with TB on a college campus, as there is a state TB program here and we are a resource for them. Also, something very beneficial to me is the connection. While I haven't been out to every single college in our state, I was at a meeting a couple months ago and had met with the gal I had sent the material out to, and she had referred a student on to get quantiferon to an out-of-state lab, because one of the challenges in our state is we are a large state and we just offer quantiferon in Omaha, which is on the eastern side of our state. So it was very beneficial to me that she was interested in TB and she knew how to refer the student on because the student did not want to take INH for 9 months. Another big thing we've really done is focus on education for groups that serve refugees. And one of our where we've done a lot of education is in Lexington, Nebraska, and it's in the central part of our state. And it's a community of about 10,000 people, and it is had been a very predominantly white community. And immigrants have recently come, and recently refugees have come to this area of our state. And there's been a lot of worries in this community about TB in their community. And what we've done is done a lot of education. It is important to note that we do not have a refugee resettlement site here, but a lot of secondary migrants do come to Lexington for work. And that we did have a community education session with the school, the hospital, health and human service workers, and anybody else that wanted to come on how to help refugees if you think they have TB and who to call. And the health department was involved in this education, but it really was beneficial to the community because what I sensed was people were getting very scared to help refugees in these types of settings, such as the school, getting health care, and also signing up for things such as public assistance. And, of course, refugees definitely need to access these services and get the information for the workers who are providing these services. Also, we did another education session focusing on the health department and local providers. And for this education, we had our state refugee resettlement coordinator talk about what a refugee is for about an hour, and then I sort of talked about TB for the rest of the education session and what is done to help follow up on these folks in our state. We've also done another education session in the clinic in this community because with the changing population, there's been a lot of questions that sort of have remained unanswered. So myself and our TB controller went out to the clinic to talk to the healthcare workers about the refugee overseas screening process, Class B refugee, and follow-up services that the state can offer. Something else that I did mention in all these is that we do offer free medication for LTBI at the state, and if someone does not have the ability to pay for TB follow-up services, how they need to contact the state and then go from there for assistance. Definitely wanted those 2 points brought out so no one would be afraid to refer someone on for services. Also, something that's new, we do have state quarterly meetings, which had not been done before, but due to the growing interest and need in this community, we do have state refugee quarterly meetings now to talk about refugee issues in this community. Another worksite issue is our meatpacking plants. As I was saying earlier, how when refugees get over here, the big push is to get refugees employed. And a lot of our refugees are working at meatpacking plants in our state. And this education was done due to a request from the meatpacking plant risk manager group, and they call themselves the Red Meat Group. And what we did for education on this group was to talk about basic TB information, contact investigation, such as if we would need to go into their work site and be skin testing people, and also about refugee background information, since many people don't know what exactly a refugee is, and also screening requirements that we don't have in our meatpacking plants for refugees that are arriving and working in the meatpacking plant. This was a very popular education, as there was a request to go back and do a second session, and that was done by the local health department. And it was also valuable because we also do have some outreach within our meatpacking plants, such as with the employee health nurse at these plants, so we can assist in following up on refugees and making sure they know about available resources and collaborating with the local health department. Something else we've done is education for direct care staff, and I've done education with the refugee resettlement staff, and that's just talking about basic TB information. The refugee resettlement staff knows what a refugee is because they are serving that group of people. But sometimes there were questions about, can I get TB? Is it okay if I'm around this refugee when they get over here? And so we really did the education to sort of calm down people's fears about catching TB. And then also there was an Employment First group called the Arbor Group who requested some education because they just wanted some more information about TB, since they do work with a lot of refugee clients and wanted some more information about TB. And both these groups really needed the education just to sort of calm down their fears so they could go ahead and do their services to help support refugees, such as the resettling process or getting a job. Another big push for education in our state has been among the healthcare providers. And our main Omaha refugee resettlement site, health clinic, is affiliated with Creighton University, called the Florence Clinic, and that is in Omaha. And there had been some question about the reliability of quantiferon. And so what we did is set up a meeting at the clinic to talk about why quantiferon is good, especially for someone that was born overseas. And we did have our university lab present to talk about all the specific studies, answer questions. The state presence was there. And then also we went ahead and have done a little pilot study with skin testing and doing quantiferon on refugees to see what kind of information they're gathering. And so the providers have a little bit more information about quantiferon and what they are seeing in their patients that they do serve. Also, something that's been very beneficial is to be at local conferences. It was very interesting to me doing a display board at the Nebraska Nurse Practitioner Conference that most of our nurse practitioners were unaware of quantiferon and the benefit it can offer to refugees. I talked about the benefits, the drawbacks, and also about if someone is positive, how we do have INH available with the state for free. And most nurse practitioners were unaware of that service. And what this gives when we get information out to healthcare providers is to give patient options and resources to help themselves. If our providers don't have the information about things such as quantiferon or free INH, then their patients are not going to be able to benefit from those services. Also, as I mentioned before, our local health departments do play a vital role in refugee and TB issues, especially those that do not work with TB on a routine basis. And it's always my goal to be knowledgeable about the populations in their community, but sometimes this can be hard working at the state, not out in the community, and to be aware of things such as cultural issues that present issues in the care of people, such as when someone is observing Ramadan, how they, don't want to take their TB medicine, issues such as those. We also have collaboration between states, and since we are a rural state, we do have limited funding, and we really have relied upon Minnesota for assistance. One of the major assistance they have offered our state is their website for language materials in a variety of languages. We see a lot of secondary migrants coming from Minnesota, and having their language materials online is a quick and easy way for us to get information out to providers or providers to access that information directly and give it to their clients that they are serving. Also, they have a DVD that is available that is new, which is nice because it's a video, but also it has audio, so that really can target people that that are unable to read, which a lot of refugees have not been taught to read just due to circumstances in their home country. And so that's a very valuable asset that we are working on at this time to get that distributed. Some of our future goals are going into the correctional facilities to target the staff and also the inmates to talk about TB and basic information about what the state offers, and that is down the road. Also, I am working on getting that Minnesota DVD distribution of the TB information out. And also, we are going to be starting quarterly conference calls among all our local health departments to go over TB cases. This will be especially valuable to our rural health departments who do not see as much TB or maybe have not dealt with certain populations, and to get the information out about things that work, things that don't work, and how is the best way to take care of people and have them take their TB medicine and TB follow-up and make it successful. And that is my presentation.
Thank you, Kristen, for sharing the experience of Nebraska as well as the experience of things that have worked for you as well. I'd like to now open up the floor for questions for the entire group. You could certainly ask questions of Kristen, but I'd also like to, again, open up so that a number of those questions that have been also sent in via the Q&A on the Internet as well as those by telephone have come up.
You do have a question from the line of Benito Renelius.
Dr. Adeline Murphy indicated that 17% of the patients are diagnosed with depressive symptoms, and they are being referred for mental health services. My question, how do they pay for that service, especially those who do not have insurance?
The patients that I have worked with are homeless individuals in downtown Los Angeles. We have a number of facilities in the area that provide mental health counselors and other types of mental health care. So they don't need to have money for those services. They sometimes have to wait a while to get seen, but they do have free health care in this downtown Skid Row area in Los Angeles.
Your next question comes from the line of Linda Flaherty.
I wanted to find out about where these refugees were from that Kristen was talking about. Where are most of the refugees from?
Most of our refugees right now are coming from Burma, but we do have a lot of Vietnamese, Iraqi, and African populations such as the Sudanese that are located in our state.
Okay. Are they mostly coming with positive TSTs, or are they B1 or B2 immigrants?
Well, we keep on seeing an increase per year. Last year we had about 80, and this year we're at about 100 for Class B refugees, and that does include immigrants also.
Thank you.
Your next question comes from the line of Jacqueline Duget.
Yes, good afternoon. Thank you very much for the presentations. This question is directed to Kristen. Kristen, I work for a local health department, and we also see the greatest number of our refugees happen to be from Burma as well. So the questions that I have are regarding the DVDs that you all are planning to, I guess, to develop or have already developed. Do you have do you have the different languages that are going to be presented to represent the different refugee populations? And if you wouldn't mind if you could share your contact information, I'd like to, we have some information in Burmese, and if you have some information, maybe we could share some resources.
Thank you for the question. The DVD is actually, that I was talking about, is the Minnesota DVD, and the languages that it's available on are, there's English, Hmong, Khmer, Lao, Somali, Spanish, and Vietnamese. And so at being a rural state, we really have to utilize other resources for development of a product like this, and that's why we're using Minnesota's example.
Because what we've invested in here in Frederick is that for some of our patients who have tuberculosis, we developed basically a PowerPoint presentation on tuberculosis for the individuals who speak Burmese. Unfortunately, if they speak other languages like Hakachin, Falamchin, we don't have that. But, I mean, that may be something we can share.
That would be a great resource, yes.
Your next question comes from the line of Elisa Jackson.
Hi, I have could you please define how you're using the term immigrant? Thank you.
This is Kristen, and we use an immigrant for someone that comes willingly to the country.
We do have a question from the line of Angie Hill.
This question is for Christine. I'm familiar with the Minnesota DVD, different languages. How do you take that out to the field for patient use?
Well, actually, I haven't done it yet. This is an ongoing project that I, have on the table. I just haven't done it yet. What I plan to do is start off with our large health departments, such as in Omaha and Lincoln, and also probably our health department in Lexington and hear their feedback. And then also I would like to send it out. We have a list of clinics where we have stock supplies of INH, where they are seeing a good amount of TB patients in their clinics. And I would eventually like to get that information out if the health departments feel it would be valuable to that clinic, or I do want to collaborate with the health department to see what other clinics in the area could benefit from the DVD.
Regina, this is Paul. I was wondering if it was also useful to mention the called a listserv that the CDC maintains for TB educational materials. I often see postings about what's available in different languages that different jurisdictions have developed. I don't know if they're having sort of a central clearinghouse function, but perhaps you know more about that.
Sure. There's the TB Educate listserv, which is more of a dynamic, real-time way of getting information across to people and sort of problem solving. But there's also the website that's maintained by CDC called findtbresources.org, which also you can sort of search out materials that exist. Some of them are CDC materials, but the majority of them are actually materials that are done out in communities. Some are international as well. You can actually search by language, by population group, target population, that sort of thing. So I'll actually put that up in our notes section so that you'll know that. Again, that's findtbresources.org. Are there any additional questions by telephone?
Yes, ma'am. You do have a question from the line of Jesus Ortiz.
This is Jesus Ortiz down in Florida. I wanted to comment on a question or comment that was made earlier regarding how do you deal with the contrast between Western type of treatments and Eastern treatments. And I had a very interesting class, my first year of med school, and it was medical anthropology. I always remember that, and I've seen it applied very true in my years of work, where tradition is a very powerful influence in people's lives. You can come to someone and explain the logic of any treatment and how it will benefit them, and somehow a lot of times those just shift back into what they're used to, into their folk medicine or whatever they've been passing down through family. And one thing that the professor there, I remember always saying, you don't have to necessarily push one type of treatment over the other, at the exclusion of the other. He said sometimes, as long as the other treatment is not dangerous or harmful, that you can emphasize how both of them may work in unison, and they work even better together. And I also want to highlight the importance of cultural sensitivity in working with the people, so that you're able to work within their system of beliefs, so you can be more effective in treating them.
This is Addie. I wanted to add one thing to what Jesus was saying. The importance of assessing cultural background and practices is also important, because there are sometimes behaviors that different people do that may be putting them at risk. And the one example that's always striking to me is among populations who inject vitamin B6, to individual family members and use the same syringe. It is a cultural factor, but it is something that we need to assess and really talk about, because transmission of infectious diseases is a big problem.
If I could just follow up, too, this is Paul, on I think what Jesus brought up about different cultures' beliefs. We know that in TB care that getting people to agree to LTBI treatment is often a challenge, because they've been told in their home countries that their BCG vaccination has caused their positive skin test, and that LTBI treatment is not important. This may not always be available to you as an option, but what we've tried to do is identify individuals, whether they be foreign-trained doctors or other individuals in the community who can serve as sort of like an ambassador or liaison to your target group, who might have a belief in our practices, in American practices, and rather than you as the American trying to convince a foreign-born group that what they've been told in their home countries is wrong, have a person who's from their group do that. Because it's often difficult to, when people come to a new country and are bombarded with a lot of new information and different information, what they've been told, it's often hard to let go of their old beliefs. That might be one way to do it.
Addie, there's been a couple of questions that have come on the line about the $5 incentive that you use. Now, I know this was a research study, but just some questions about where the funding came from, and then did the incentives continue after the trial was over, the research you were doing?
The funding came from the National Institute on Drug Abuse, that's NIDA, so it was an NIH-supported study, and at the end of the study, the money also stopped, but we actually assessed completion. We were able to time the study so that people either completed or did not complete within the reasonable period of time. And I think actually that there may be some health departments that are looking at that. In terms of cost effectiveness, it is important to evaluate whether the long-term implications of not receiving treatment is what the impact of paying $5 might be to the alternative of somebody becoming actively infected and infecting other people. So that's a health policy issue that one needs to look at.
You have an additional question from the line of Victoria Messer.
Hi, this is Vicki Messer. I work for the Department of Corrections in the state of Nevada. And my question is, we have 5 large prisons up here, and our networking isn't the best. A lot of our inmates that come in here and test positive but have a negative chest X-ray are either picked up by ICE, and there's no way to follow up, and then they come back, let's say, in 6 months, or they go to one of our other prisoners, and I never know if they finish their meds because at the prison I work at, I'm the only nurse in charge of all the testing and reading and getting the LFTs done and issuing the INH and vitamin B6. But when they go to another prison, they won't have a nurse that's in charge of that, and anybody takes care of it. And I feel I'm really losing a lot of our Hispanics people through the cracks through the prison system, and I don't know what would be the best networking for us.
Kristen, might you answer that, since I know you've done some liaisoning with the correctional system?
I haven't actually been involved in our correctional facilities yet. Like I said, that's a goal of my next year to do, but I know just what I've heard from other people in my state working with corrections, it's a challenging group to collaborate with and get information on. And from what I've heard is the opportunity to collaborate is very difficult in our state because providers aren't encouraged to network. The continuing education opportunities are not encouraged.
No, there isn't. And I hate to say that because I would really like to see it done. I just see, for the community, and when they do go out, there's no follow-up. There's no, even if I call other nurses at another prison, I go, yeah, he was here, is he gone? Well, can you tell me if he finished his 6 months of INH vitamin B6? Oh, I don't know. I don't have his records. They're in archives. So here we are treating these people, testing them, treating them, educating them, and then if they leave before the treatment period is over with, I don't know what's happened.
I think you just pointed out it's a very hard group to work with. I think, educating inmates is a big thing. I'm going to try that this coming up year. But, I mean, these people have lots of issues, and health care is very difficult for them to access, and it's probably not at their top of their priority to seek follow-up care for TB treatment.
Okay.
Vicki, could I ask a question back? This is Paul.
Hi, Paul.
My understanding is often difficult in a jail situation for a person to complete LTBI treatment because of shorter stays in jail and more movement. But in prisons, my impression always was that people's stays were more predictable and more long-term. It sounds like you're still saying that it's difficult that people are transferred or released.
Either they're here because they're going, let's say their sentence is that they have to go to boot camp. Well, boot camp doesn't have a nurse over there. And a lot of times if I catch it before the caseworker is transferring to boot camp, I can say, no, he can't be transferred. He's a positive PPP. and he's starting on his medications this week. They'll keep him here. But then a lot of guys, their sentences only for, they come from jail and their sentences, they only have 4 months left, and then they expire, or they get in a fight here and they're transferred to another prison. It depends on what's happening.
I'm not sure how much help it will be in the circumstances you described, but perhaps you want to look at the literature by Mary Castle White, who's in San Francisco, who's written a lot about LTBI treatment in jails.
Okay.
And then following people in the community once they leave the jail.
Okay.
Mary Castle White, again, is her name.
Thank you for the question, and Paul, for your answers. We'll try and find some resources. I know that some of the RTMCCs have done quite a bit of work with the correctional population, with the personnel in correctional facilities, so certainly we'll try to post some resources related to that as well.
That would be great.
Unfortunately, we're out of time. I would like to thank the faculty today for sharing their knowledge and experience with all of us. This was a really wonderful session of sharing of resources. We got some good participation as well. I want to thank you all again, including our faculty and all of the participants, for the great discussion and questions. This concludes today's conference. Thank you for your participation.